Parminder, I think we start.
Right, ma'am. Am I audible, ma'am?
Yes, and the slides are visible.
Yeah. Good evening, everybody. I'm Dr. Parminder from AIIMS New Delhi. Today we have a case discussion, neonatal encephalopathy with hypotonia. So coming on to the case details, my patient, baby of S, born at 35 weeks period of gestation with birth weight of 2005 grams, AGA baby. In the mother's obstetric history, the mother was G5, P2, L2, A2. The first pregnancy was 15 years back. Term vaginal delivery, uneventful antenatal period, female baby who's live and healthy. The second pregnancy was 12 years back. Again, term vaginal delivery, uneventful antenatal period, male baby who's alive and healthy. The next two pregnancies resulted in spontaneous abortions, and this was the fifth pregnancy. The antenatal history of all the 3 trimesters in this pregnancy was more or less uneventful. In the antenatal investigations, mother's blood group was O positive. Viral markers, VDRL, were non-reactive. HP was 10.6 and TSH was 6.5. Anomaly scan showed mild bilateral ventricular dilatation with mild hydronephrosis. Maternal CMV in the form IgG and IgM was both positive, with CMV showing high avidity. Amniocentesis was done, in which CMV PCR was positive, toxoplasma PCR was negative. At the same time, the amniocentesis revealed a balanced translocation between chromosome 5 and 14. However, chordocentesis showed that CMV PCR was negative. Fetal MRI showed mild hydronephrosis, mild cerebral atrophy, and mild bilateral hydronephrosis. A detailed pedigree analysis revealed that this was a third-degree consanguineous marriage. Coming on to the course of this baby, it was a spontaneous vaginal delivery. At 2 minutes of life, baby was found to have respiratory distress, for which CPAP was initiated. The baby was also found to have facial dysmorphism. If you look at the photograph here, the baby was found to have mild epicanthal folds, long philtrum, absence of eyelashes, eyebrows, and frontal scalp balding. Otherwise, there was no limb or genital or any other significant dysmorphism or congenital anomaly. The baby was shifted, started to NICU, started on PEDS, initially found to be active and inert. The initial investigation of this baby was more or less normal. The initial anthropometry parameters, the height, head circumference, weight, head circumference was within 10th and 50th centile. Length was less than 3rd centile. Other than general, in the general examination, other than facial dysmorphism, the rest of the systemic examination was within normal. Now, at around 36 hours of life, the baby was found to have decreased activity, decreased movements, and a detailed neurological evaluation revealed that the baby was having encephalopathic features with global hypotonia. At the same time, the baby had an episode of suspected seizure, which was focal clonic, involving left upper limb, lasting for around 30 seconds. The baby, at the same time, also had features of tachypnea, desaturation with minimal distress, for which initially baby was started on oxygen through free flow. Later, because of the distress part, the baby was shifted to H3FNC. The neurological examination of this baby at this point revealed that the baby was more or less obtunded. The AF was full, non-bulging. The baby showed minimal state-to-state variability. There was gross hypotonia, both axial and appendicular, involving both active and passive tone. If we can see the photos on the right, the baby had severe head lag, and the baby was more or less in frog position with no flexor tone, which was expected of this gestation. The other active tone, passive tone showed a gross hypotonia, which was very distinct in this baby, along with the features of encephalopathy. Also, the neonatal reflexes were grossly reduced. Sucking was poor. Plantar palmar grafts were barely elicitable. Moros were barely elicitable. However, deep tendon junk reflexes were present. Now, getting the investigations done based on a sudden deterioration in a baby who was clinically normal. The initial investigations, as per protocol, which we had sent, hemoglobin was within normal limits to rule out infection. TLC, ANC was normal. A normal platelet count, RFTs, serum electrolytes, along with LFTs were also within normal limits. USG abdomen, we had got it done along with cranial USG. USG abdomen, mild to moderate hydronephrosis. Cranial USG, other than mild ventriculomegaly, more or less, it was within the normal limit. We'd also got a functional echo done because of sudden deterioration and suspicions of other disorders, which was also more or less normal. The cardiac contractility was normal. The baby did not have any congenital cardiac anomalies associated. So with the clinical investigations and neurological examination and the clinical profile, we started ruling out the common causes first, and then gradually build up onto a differential diagnosis once these common causes were ruled out. So we had kept first as hypoglycemia. So what we found that blood glucose was normal. There were no hypoglycemic episodes throughout the hospital stay. The baby is still admitted with us, but the baby never had any hypoglycemic episodes. So that was one thing which was ruled out. Then common causes, polycythemia, the PCV at that time was 62%. Then infection, definitely. Meningitis as a cause of acute deterioration that we wanted to rule out. So antenatally, there were no risk factors other than spontaneous prematurity. At the time of deterioration, there was a prolonged CFT. Otherwise, the baby was more or less hemodynamically stable. We had done a CSF tap at that time, which showed non-meningitic picture along with blood and CSF cultures, which was sterile. So once the common possibilities were ruled out, we moved on to the other possibilities in this baby, which were kept. One was congenital CMV, since the mother was also having congenital, mother was CMV positive. Metabolic acido disorders, inborn errors of metabolism, a structural malformation which could explain the gamut of clinical features which the baby had, and rare genetic causes lower down on the graph. So congenital CMV more or less was ruled out because the baby did not have any clinical features congenital CMV. So we had got the baby worked up. Fundus showed no chorioretinitis. Cranial USG, other than mild ventriculomegaly, was more or less normal with no calcification. CMV PCR in all three fluids, which is blood, urine, and CSF, was negative. So more or less congenital CMV was ruled out in this baby. Now, with a picture of a syndromic baby having hypotonia, having encephalopathy, with ventriculomegaly and a balanced translocation of 514 in amniocentesis, what was the possibilities that we were considering? It gradually narrowed down again to IEM, to a genetic cause, to a structural cause. Now, why did we think of metabolic? Clinical pointers, if we see a deterioration after a period of apparent normalcy, parental consanguinity, encephalopathy, seizures, though single episode of an unexplained cause, and transient metabolic acidosis, which the baby had in the time when there was sudden deterioration. Now, keeping the metabolic possibilities, we've got the metabolic workup done, as I mentioned earlier. Glucose records, more or less, there were never any episodes of hypoglycemia. The lactates remained within normal limit. Plasma ammonia was also within normal limits. Ketones were never deranged. We gave a trial of feeds and repeated the GLAC to see any significant worsening in the metabolic parameters. We did not find any. After reintroducing of feeds, also the baby repeat GLAC was within normal limit. There was a initial period of transient metabolic acidosis which the baby had, which was associated with the initial clinical deterioration. However, within a span of 3 to 4 days, this transient metabolic acidosis gradually resolved. So in the metabolic parameters, if we see the significant chunk which we think of diagnosing inborn errors of metabolism, the GLAC was more or less normal in this baby, and repeat values were also normal after starting feeds in this baby. So now with neurological manifestations, hypotonia and seizures, we try to find out possible causes of AIIMS which could fit into our provisional diagnosis. And if we see differentials of AIIMS affecting the neurological status of a baby per se, they're broadly divided into either being associated with metabolic acidosis, hypoglycemia, and hyperammonemia. Hypoglycemia and hyperammonemia were ruled out in our case, so we focused more on less on metabolic acidosis. A long list, right from organic acidemias to fatty oxidation defects, to glycogen storage defects, to mitochondrial respiratory chain disorders. We further try to narrow down with hypotonia. So we could find only 3 to 4 disorders which had predominantly hypotonia as a symptom in them. So it was mitochondrial respiratory chain disorders, Zellweger's glycine encephalopathy, and associated seizures. Seizures, again, we had a long list. However, there was just one episode of seizures in this baby, and that too also was controlled with a normal dose of phenobarbital loading followed by maintenance. So it was never that the baby had recurrent seizure episodes and difficult to control seizures, which are common features in most of these seizures associated with IEM. So narrow downing with AIIMS involving facial dysmorphism. Now, if you see the photos on photograph on the right, we have a classical picture of a baby having Zellweger's, wherein we find a large fontanelle, prominent forehead, flat nasal bridge, apicanthal folds, hypoplastic supraorbital bridges. Our baby did not fit into the phenotype predominantly of a Zellweger syndrome. Then we have glutaric acidurias, wherein there is macrocephaly, high forehead, flat nipples, short nose, ear anomalies. Disorders like congenital disorders of glycolization can present with inverted nipples, lipodystrophy. So more or less, though the baby had subtle dysmorphism, but did not fit into any classical dysmorphic IEM which presents with dysmorphism. So narrowing down to the possibilities in our baby, we had kept as Zellweger's higher on the cards. Non-ketotic hyperglycemia, again, seizures is a predominant feature in non-ketotic hyperglycemia, and baby would be having difficulty in controlling seizures and presentation much earlier. So again, but because non-ketotic hypoglycemia is also associated with encephalopathy with seizures and hypotonia, so we had to keep it as a differential. Sulfite oxidation deficiency, a rarer cause of hypotonia. Congenital disorders with glycolization, though did not have typical syndromic features as mentioned, which the baby's dysmorphism, which the babies usually have, but then they also have hypotonia and mitochondrial respiratory chain disorders. But the issue was lactates were more or less normal most of the times in our baby. So we consider these possibilities as in our case. Meanwhile, we could get a brain MRI of this baby, and diffusion weighted of image of this baby just showed mild ventriculomegaly. More or less, the MRI was within normal limits. So these are differentials of keeping a structural possibility, lissencephaly or a scissencephaly or heterotrophias, which could explain the features of encephalopathy with hypotonia and seizures, were more or less ruled out with the MRI being more or less normal. Mild ventriculomegaly was still present. Meanwhile, we got the consultation with the pediatric neurologist also just to see if we were missing any neurological cause per se that could define the diagnosis in this baby. So we had got the EEG done in this baby, which showed basically an immature background with right hemispheric epileptiform discharges. We were expecting a possibility of non-convulsive status, which could explain the encephalopathic features and the gross hypotonia in this baby. That was not there in this baby. However, because of the hemispheric elliptiform activity, the baby was started on levetiracetam along with phenobarb. That was continued initially after the seizure episode. However, the baby never had any seizure recurrence throughout the course of the illness. So once the common causes had been ruled out, by this time we had the TMS GCMS report, and to our surprise, what we found as that the TMS GCMS reports were more or less negative for the most of the disorders that we had considered in this baby. And if we see what all was ruled out, it was organic acidemias, amino acidopathies, fatty oxidation defects, and peroxisomal disorders also. And if we look at the reports, you can see this is the TMS, the panel which was sent. More or less, the common metabolic syndromes have been ruled out. And in the GCMS, also, if we see peroxisomal disorders, disorder of pyrimidine metabolism, and other organic acidemias have also been ruled out by doing TMS GCMS. So with this TMS GCMS and GLAC being normal, the possibilities of a metabolic disorder were kept much lower in this baby after the initial investigations, to our surprise. Now, with structural causes ruled out, with AIIMS being more or less ruled out, though we could not definitely say TMS GCM is not 100% specific, there can be rarer disorders also. We were left with genetic syndromes which could explain the condition in this baby. So what we could narrow down is basically syndromes presenting with hypotonia. They don't explain the encephalopathy per se, but syndromes like Prader-Willi, Anderson's, Zellweger's Downs, 5p trisomies, and rare microdeletions can explain basically these encephalopathic features and gross hypotonia in this baby. Further course, the baby continued to remain encephalopathy. However, there was slight improvement in the sensorium. There was never a seizure recurrence. Transient metabolic acidosis, as I told, and initially the baby did have features of polyuria, which resolved on its own. The feeds have been gradually built up, and there was no hemodynamic instability. However, on day 12 of life, the baby suddenly developed features of NEC with features of nematosis, intestinals, and USG showing no free fluid or portal gas, and mild hydronephrosis, mild to moderate hydronephrosis, which was persistent. That continued in this case. The current status of this baby is we are managing this baby for NEC, and his NEC features have more or less resolved after keeping him NPO and antibiotics, and MEN has been gradually restarted. The neurological status, though there is slight improvement, but most of the times the baby is drowsy. Occasional spontaneous eye opening has started and movements have improved. However, minimal state-to-state variability continues. The baby continues to be on phenobarbital and levetiracetam. Plan for this index case is once most of the common causes of IEM structural have been more or less ruled out, we are left with genetic syndromes for which chromosome microarray reports are awaited. Possibility of a rare microdeletion which can explain most of the cases. Unlikely to have a metabolic disorders, but rarer IEMs which can be missed in TMS, GCMS still can be possibilities. Plan is to gradually build up feeds, involve the parents in care, and initiate physiotherapy and occupational therapy so that we can plan to discharge the baby gradually, provided we have a definitive diagnosis in this case by the time the genetic reports are available for us. So this was my case per se. Now coming on to the discussion part, I'll not go to the IEMs per se, because it's a very broad spectrum, and our baby did not fit into IEMs per se, though we were speculating. I'll keep the discussion per se to our baby itself and talk about specific inputs in this case. So like commonly when we think of a metabolic cause, when there is a parental consanguinity, there's a deterioration after an apparent normalcy, history of family, neonatal deaths, neurological illnesses, rapidly progressive encephalopathy, severe metabolic acidosis, and books though have mentioned unusual odors, but they are rarely found in common metabolic disorders. In the diagnostic clues, if there is metabolic acidosis, if there is ketosis, if there is hyperammonemia, lactic acidemia, hypoglycemia, then the chances of the baby having an underlying metabolic cause are much higher. Moving on to the classification of AIIMS, the age-old classification of a small molecule and a large molecule tends to explain the things better, though the Society of Metabolic Inborn Errors of Metabolism have now divided the inborn errors of metabolism into 15 other categories, basically depending on whether there is a substrate build-up or there is a deficiency or intoxication. But small molecules or a large molecule basically is a concept which helps to understand the AIIMS better. Classical teaching of small molecule is basically an intermittent worsening with a febrile illness, unexplained illness, dystonia, chorioathetoid movements later in the infancy period or childhood. There's failure to thrive, recurrent vomiting, unexplained global developmental delay, hypotonia, extrapyramidal symptoms. When you come to large molecules, basically storage disorders, basically present with the neuroregression, post-facies, seizures, hepatosplenomegaly, and insidious and a progressive course, very later down in the infancy or the childhood period. Then presentations can be again divided, basically affecting the neurological part per se, or involvement of hepatic, cardiac, or syndromic approach. So we can divide the AIIMS and their management can go according to the presentation, which is a predominant symptom in the AIIMS per se. So in neurological, there could be encephalopathy, seizures, hypotonia, apnea. Hepatic causes hypoglycemia, cholestatic jaundice, liver failure. Cardiac, a very small number wherein cardiomyopathies, arrhythmias, heart failures could be there. And then there could be syndromic associations, as I've already mentioned. So if you look at the flow chart, these flow charts are commonly available, and there is a algorithmic approach based on what the abnormalities we find in our GLAC. And at times it becomes easier to pinpoint to a specific diagnosis, but at times in our case, it becomes difficult also. So if we see the follow-up, no metabolic acidosis like in our case, which gets quickly resolved. Persistent hypoglycemia did not happen in our case, so we could think of, if there was presence or if there was ketosis or absence of ketosis, we could think of hyperinsulinemia or fatty oxidation defects. Then we could think of hyperammonemia, which was again not in our case, so urea cycle defects would have been a big significant chunk in that case. And with normal glucose levels and normal ammonia levels, we were left with peroxisomal disorders and congenital disorders of glycosylation. Metabolic acidosis, which is excessive, not resolving as expected, with no anion gap or anion gap present. And then if there's no anion gap, we could think of the same flowchart. If there's an anion gap present, then we have to think of other causes: hypoxia, sepsis, bowel ischemia, or poor perfusion. We try to rule out most of the causes in this case. Bowel ischemia was there in the form of NEC, was much later in this case. However, feeds we could build up in this baby. So most of the causes which have been listed, we've tried to rule out in this case. So again, when we have a suspected, again, the flowchart which we commonly see when we think of metabolic acidosis and we do ammonia levels. So based on the available parameters, so our baby fits into the last, wherein there was pH was normal, there was transient metabolic acidosis, hypoglycemia was not there. So a limited number of disorders, as we had already discussed, fit into this gamut, wherein most of the metabolic parameters are more or less normal. Then we have algorithmic approaches based on whether there is hyperammonemia, predominantly respiratory acidosis, if there is there, and then we can go on to differentials of urea cycle defects. I'll not go into the exact disorders because our babies did not have ammonia rays. But the point that I want to make here is there are algorithmic approaches, and things can be narrowed down based on the GLAC per se. So there are algorithms which are commonly mentioned in standard textbooks if there is hypoglycemia, and how to go about with the presence of acidosis, ketosis, and then the differentials will be narrowed down on the diagnosis per se. So in a case of AIIMS, as commonly what we do is to stabilize the baby, get a detailed history examination, rule out the common causes which can be a differential like sepsis, hypothermia, aspiration, and metabolic workup has to be sent. A basic metabolic workup which we all commonly send GLAC along with RFTs and hemograms to rule out the other causes. Once we are if we don't get anything, or if we are missing on the first line investigations, then we move on to the second line investigations. Meanwhile, we continue the acute management of a baby who's suddenly deteriorated, and we think of a metabolic causes. The second line investigation would be TMS, GCMS, the HPLCs, lactate pyruvate with ratios, urinary orotic acid in urea cycle defects. Limited AIIMS wherein enzyme assays can be then biotinase deficiencies, galactosemia. Neuroimaging can be, there are AIIMS with specific features of on MRIs. Then MRS, various lactate, various peaks which we have can also help us in narrowing our diagnosis. EEG, though classical books have mentioned comb-like rhythm in MSUD, burst suppression. So again, that can aid into the diagnosis. Very long chain fatty acids in cases of paroxysmal disorders, and genetic analysis and mutational analysis wherever feasible. The acute decompensation is basically wherein we don't want the substrate to form. If it is formed, we want to make sure that it gets excreted by an alternate pathway. We want to replace the enzymes and cofactors. At the same time, stabilize the baby, treat the acute symptoms of hypoglycemia, acidosis, take care of the metabolic toxic metabolites, and hold on the feeds for 24 to 48 hours to see whether there is any effect after starting or stopping of the feeds. Once a gamut of metabolic disorders were ruled out, we were thinking of any differentials that we could think of in terms of neonatal encephalopathy per se, which the baby was having. So what we see is, if you look at the causes of encephalopathy, a major chunk is HI, which this baby did not have. And then most of the causes which have been listed here were ruled out: malformations or vascular malformations, CNS infections, and acute metabolic disorders, epilepsy syndrome. So more or less, we had ruled out a major chunk of more or less all the causes which can lead into an encephalopathic state in a newborn had been ruled out in our case. Then we try to further broaden our spectrum, and we try to focus on hypotonia per se, and we were thinking that we should not be missing anything in terms of our chasing the metabolic parameters and encephalopathy part per se. So we try to look on to causes of newborns having generalized hypotonia. So a detailed history and physical examination. Hypoxia is again a very common cause. If there is no hypoxic injury, then we try to see whether there is a peripheral or a CNS cause, like we commonly do. So in our case, CNS was involved, and there was hardly any pointers towards a peripheral neurological system involvement because the deep tendons reflexes were present, and the clinical features more or less fitted into a central cause rather than a peripheral cause. So a central cause would be basically related with encephalopathy, microcephaly, public features, and then in this we need to consider AIIMS, chromosomal disorders and structural disorders, as I told, dysencephaly, grand heterotopias, which could explain the cause and causes of hypotonia. Again, looking at hypotonia in per se, in this flowchart, we just wanted to focus on hypotonia per se. So this is normal creatine kinase with global developmental delay along with dysmorphism. So again, we have boiled down into the similar causes only, and more or less on clinical examination along with investigations, these causes of hypotonia have been ruled out more or less. So coming into the summary of the case, see, newborns with AIIMS have a very limited repertoire of syndromes with overlap. Both clinical and biochemical parameters help us in clenching the diagnosis. History of unexplained sibling death or a parental consanguinity should alert us towards, point us towards IEM. GLAC or an algorithmic approach, the algorithms based on hyperammonemia, hypoglycemia, metabolic acidosis are available in all standard textbooks, and they help us in narrowing down to a diagnosis, provided there is abnormalities. Many of the IEMs, once if we can zero down based on TMS, GCMS or genetic evaluation, can be treatable in the today's scenario. And genetic counseling has a very important and a subsequent role to play in IEMs. And maybe in the coming years, we would be relying more on genetic evaluations, much more to give answers to unexplained encephalopathies and seizures, like in our case. With this, I have come to the end of my case presentation and discussion, and I would now be taking up the questions from the I'm ready for the questions and regarding this case, if there is any from the
Parminder, there are some questions in the chat box, so you can answer them one by one.
Right. Please explain state-to-state variability. State-to-state variability, what I meant was the baby, the state of in the neurological examination of the newborn, there is higher mental functions, wherein we comment on the state of awakeness of the baby, wherein Fletcher's 5 stages are there, and we define the variability. What I mean by this is that the baby is continues to have variability in the state. He does not remain in one state, wherein in our baby, the baby was in predominantly state 2, which is more or less sleeping with occasional movements and eyes closed. State 3 is when the eyes are open and there is minimal movements. State 4 is when the eyes are open and baby is actively moving. State 5 is when the baby is crying. So state-to-state variability tells us about the neurological status of the baby, which was missing in our case. So baby was predominant in state 2 of awakeness in the higher mental function state of the Brechel's chart. The ma'am has already explained this in behavioral states. Why was translocation 514 investigation? Basically, amniocentesis was sent for this baby, and at the same time, there's a policy when we send amniocentesis for CMV, we do send for translocations also. And so incidentally, 514 translocation was detected in this case. It was a balanced translocation. It does not explain the neurological status of this baby in this condition. So that's the reason why translocation was, karyotype was also already sent in this case, along with amniocentesis, which is a protocol when we send for samples. So that's where translocation of 514 was seen. EEG features I've already mentioned. There was no features of non-convulsive status, and though there were right hemisphere showed some epileptiform discharges. However, in consultation with speech neurology team, we could not narrow down to a specific cause which could explain the encephalopathy per se, and the baby did not have any ongoing seizure activity which could explain the features on EEG. Yes, the baby only had one episode of seizures. Amplitude integrated EEG was not done because there was no recurrence of seizures. However, we had got a 16-channel EEG done, and it was reviewed by neurology team also. And these findings have already been mentioned in the slides that I had shared. Size of the lateral ventricles, there was no gross dilatation. There was mild ventricular dilatation of ranging from 10 to 11 mm only. So it was not a very significant ventricular dilatation. Repeat USGs also showed around 12 mm size. Initially, it was 10 to 11 only. Repeat cranial ultrasounds and MRI also did not show very significant ventricular dilatation. No burst suppression. We did not try pyridoxine because there was never a difficulty in seizure control, and pyridoxine role in this case was not warranted because we were thinking of rare disorders. Pyridoxine would come into play only when there is interactable seizures which are never been able to be controlled on multiple AEDs. So in this case, we just had one focal seizures which was adequately controlled in by giving normal dose of phenobarbital along with initial loading followed by maintenance. So the question of using pyridoxine did not occur in this case. Why somebody's asked, why don't you confirm whether it is a central or peripheral before going to labs, which was already done when we had examined the baby. I had mentioned initially in the slide itself that the deep tendon jerks were already present. So peripheral cause more or less had been ruled out. At that time per se, also we had ruled out the causes of hypotonia in this baby per se. Actually, the reason why we had mentioned hypotonia in the last was basically because we were trying to rule out the commoner causes. Once the commoner causes had been ruled out, we tried to find out whether it's just hypotonia that we are dealing with, and we were trying to find out differential causes of the hypotonia. So in the initial examination itself, we had ruled out that it was a central cause. So it was just that the flowchart, the discussion, we had brought it in the end. Diagnostic possibility in your case, as I have already mentioned, most likely it seems to be a microdeletion, which seems to explain the cause in this baby encephalopathy with hypotonia. Rare microdeletions, though they will not be fitting into all the diagnosis, are the possibility which we are looking at in this baby. AIIMS, as I mentioned, have more or less been ruled out in this case. Uric acid was done anytime. No, uric acid we did not do in this baby. Ma'am, I answered most of the questions.
Yeah, thanks, Parminder. And Dr. Kasula, we still don't have a final diagnosis on this baby. And hoping to get some information on chromosomal microarray, because essentially the inborn error of metabolism workup, including the TMS and the GCMS and the initial metabolic screen was normal. And in addition to that, even after introduction of feeds, there was no neurological or setback or deterioration seen after full feeds. And baby is undergoing physiotherapy and in the unit, mother being trained for feeding, and we'll get back to the team in the group as well as otherwise the moment we have the CMA report, if there is some suggestion on that, and we're expecting that in another 2 weeks from now. So Parminder, they're asking about whole exome sequencing.
Yeah. So as of now, we plan to get CMA first, and then possibly CMA does not clinch the diagnosis, then possibility of getting whole exome sequencing would be there in this case.
Yeah, the other problem with whole exome sequencing is it comes with a cost. And the second thing is that it will be like firing in the dark. Reason being that even if you get, you really don't know what kind of clinical correlate it will have. So let us see the report of CMA. If we have no suggestion, then we'll discuss with the genetic team and then discuss the option of sending a whole exome sequencing. Yeah.
Was COVID encephalopathy ruled out? Actually, this baby is with us for a very significant time. And it's been 1 month that the baby is there. So COVID at that time was not as and we are not monitoring. No, the mother did not have any features of URI or COVID exposure during or after the delivery. So COVID encephalopathy unlikely in this case, because the baby never had any features. Neither did the mother had a history of exposure, or was COVID a concern at that time? This is around 1 month that the baby was delivered, 1 month back.
So if there are no more questions, I think we can close. And Artira, we did not send mother's COVID, and no, we did not keep that as one of the differentials, either at the time of presentation and nor at the time during the course of illness, because there was nothing to suggest the same. Yes, you would keep it as a differential, a rare possibility though, but then in our setting at that time with the nadir of cases being reported, and so we did not keep it as one of the differentials at the time of when the baby presented to us. Yeah. Right, so Dr. Kasula shared that he has seen a series of neonatal hypotonia. Few of them were myopathy, some bifurcation protein deficiency, right? So I think that if there are no questions, Parminder, we can close the presentation and share the recording with Dr. Samad after the session is over, Parminder.
Right.
Yeah, thank you everyone. Good night.